A very good morning to the moderator on the dais and for this opportunity to present in this national symposium. I don't know how many of you in this audience are doing SMILE, but then there's always a place to understand the challenges which come in with every refractive procedure. Essentially, evolution of SMILE has been a process in refractive surgery where it came with promises that it's going to get flapless, more biomechanical stability and all. But there was also one thing which we noticed was that in a LASIK procedure, if you look at the incidence of enhancement rates, it claims to be anything from 5 to 28%, whereas in SMILE, it was only about 2 to 2.9%, which was a study done in 2 years. And of course, if you look at the refractive stability and the predictability, which this were, or both of them are 5-year studies, which is also very encouraging, that SMILE, yes, it is a favorable answer in that limited myopic correction of about 10 to 12 diopters. Then, the reasons why do you get enhancement, in need to do enhancement in SMILE would be the undercorrections or the overcorrections or the wound healing and the regression. The undercorrections and the overcorrections are something which you're going to know the very next day after the surgery that you have not corrected this much, so you've gone wrong in your refraction. But regression is something which can kick in as early as 2 weeks and could even present itself over 2 years period. So when do you treat these eyes for enhancement? So it just like as you would be very stringent in selecting your patients for refractive surgery, you need to become even more careful when you're doing an enhancement procedure because these are already treated corneas, thinner corneas, so we need to address that. And most importantly, we should also look at the topography beside the corneal thickness, whether it's a regular topography, are you justified in just doing a wavefront guided treatment, just a re-SMILE or whatever, or would you have to do a go ahead and regularize these corneas? So then we need to look at the traditional, what are the risk factors which cause regression? So these are patients who have very high myopia or high hyperopia, who have a low corneal thickness, wherein you have a smaller optic zone, or you have a high astigmatism. Now, why is it in high myopes and smaller optic zone and high astigmatism, you have more regression? Essentially, it is based on the hypothesis of change in curvature change which happens. So curvature change is more in these high corrections and astigmatism, and when there is a greater curvature change here and in smaller optic zone, the epithelium tends to grow more, there is more epithelial hyperplasia and more epithelial modeling. And again, interestingly, which was quite a news for me too, people older age group, I thought it's a younger age group. So in the younger age group, you need to be careful for ectasia, and in the older patient, there is more epithelial hyperplasia and epithelial thickening which occurs. Again, in excimer-based procedures, the humidity and the temperature are the fluence which gets altered have also to be kept in mind. But what is the risk factor specific to SMILE? Then again, age group over 35 years has been seen in most patients. But in SMILE, even with a refractive error of over 6 diopters, you need to be a little wary of regression which would trickle in because of the thicker lenticule which is removed and the greater change in curvature. Again, high astigmatism, even from 3 diopters onwards, you need to be careful. But the fourth interesting data is an intraoperative suction loss in SMILE could be a harbinger of getting regression. Why is it so? It is seen that fondness, there is a challenge in the centration. When there is already a lot of OBL, you're not, it obscures the view, so it is a bit of a challenge to ensure that you have the same centration, that you're docking in the same area. There's some amount of tissue edema which is already created because of the earlier lenticule cut. And then this repeated cutting, there is some more distortion of the stromal lamellae which is seen, and these are said to be causes for getting regression in these eyes. Now, if you look carefully, now, why is it not? Sorry. If you look carefully, it's not moving at all. Sorry, essentially, anyway, my message is that we need to redock very carefully when you have an intra-op suction loss and ensure that if it is exactly overlapped, your lift of the flap gets easier. Now, this was the same. Oh, it's happening here. I'm sorry. You can see, I'm very sorry. So you can see the difficulty which I face in the separation of the lenticule. It was just a regular suction loss which had happened, and when there is so much trauma which is occurring in interlamellar area, there's more amount of apoptosis and more amount of release of inflammatory chemokines, and all of this would definitely alter the wound healing response and cause regression. So then the next question is, when you have to do enhancement post LASIK, you would either do a PRK or a flap lift. PRK after flap lift for the first 3 years, and after 3 years you would look at PRK. But for enhancement post smile, we have to be more strategic. Because we need to understand what is the degree of enhancement which is required. That are you looking at very small diopter of correction or a little more? And then you need to look at the anterior cap thickness. If the anterior cap is quite thick, then you could do a laser, a thin flap LASIK or a PRK. If the residual flap thickness allows, you could do a secondary smile procedure, or it depends whether the patient wants to remain flapless. So these are the different options which come forward for doing a smile procedure. Now this was a regular case of a patient who underwent a regular procedure, regular topography, and he ended up with a small amount of residual refractive error. The patient was insistent on getting a refractive procedure. You looked at the epithelial thickness, there was no significant epithelial hyperplasia, and we decided to go in and do a PRK over smile, because you can't do a re-smile, and because the lenticule would be very thin in these small refractive errors, and a smile, but if this had been a little irregular topography, a little irregular astigmatism, then you would have done a topo-guided treatment, PRK, instead of just a wavefront optimized PRK. But then, yes, we have to keep in mind, you have to explain to the patient, there's a slower recovery, a little more pain and haze. In fact, there was a study which compared PRK, flap, thin flap, and smile, post-smile after enhancement, and they found that the inflammatory response was more significant in doing a PRK after a smile procedure. But then this haze and all these reactions all settled by 28 days and did not matter at all when you look beyond that period. Thin flap LASIK can be done if the cap which you have created is about 120 to 130 micron thick. Then you could create a thin flap, but you should remember that it should not impinge on your original interface, and care should be taken that these gas bubbles, there's no breakthrough and there's no buttonholing. And also, if there is a gap between, if the gap between the two cleavage plane, the primary plane and the secondary plane is very small, the bubbles could come and create punctures in the corneal stroma during migration. You could do a secondary smile anterior or posterior to the smile. I have a limited experience, and probably the experience overall is also limited, but if you want to do anteriorly, it has to be a thicker cap. The other very popular procedure is the circle procedure, wherein you could essentially you create an incision plane around the original cap, enlarge the diameter, and then lift the flap, and then it becomes a larger interface. That is called as a lamellar ring with a side cut and a hinge which gets created. There were different ways of doing it. From the pocket, you could just go in and enlarge the incision and have one circle, but it's a small diameter flap which is created. Or you could create a flap deeper to the original cap, or you could create a lamellar ring superficial to the pocket, or you could do an incision on the same level as the pocket. As I show the video, you would understand better, wherein you are able to go on the same level as the original smile and just increase the flap diameter and lift the flap appears to be the way to go. Now, if you look carefully, this is the D pattern which has been done. So essentially, you need to dock. Centration of docking in smile is very important because you do not have eye trackers. So these patients essentially are centering on the visual axis. So what you're doing is you're increasing the flap diameter, going on the same plane as the original cap cut. And then, so this is called a lamellar ring which is created. And then you just go in and just lift it up as is being shown. And just all you have to do, there's a hinge, and then you just lift it up and gently move the flap as you would just lift a flap in any femto laser flap procedures. And once you have lifted the flap, you completely evert it. There's no way of fast forwarding in this. And then you do excimer laser ablation, and you put the flap back. Phakic IOLs, of course, have a very limited requirement because enhancement is needed for very small residual errors. So either you're going to do a PRK or a thin flap LASIK or rarely a smile. A phakic IOL has hardly much role to play. So I would like to conclude stating that yes, when you're doing an enhancement, you're losing the advantage of smile because you're now limited by the variables of the excimer laser. But then one thing we remember is you're creating a fresh cut to create a flap called in the circle software. So there is no, it is not going to be challenged by the epithelial ingrowth, which could happen if you're lifting up an old flap. And the inflammatory response in all of these are so minimal. So a possibility of a secondary regression over the primary regression is far less in smile. So it's definitely a more encouraging thought. Thank you.